Okay. Hello, everyone, and thank you for joining us for our March episode of the Housing Solutions Speaker Series, which exists to highlight the variety of housing research and practice and their connections to health and health equity. My name is Rashanik Medipana, and I'm the director of this initiative. For those unfamiliar with what we do, the Housing Solutions for Health Equity Initiative informs local, state, and national policy through interdisciplinary research on housing as it relates to equity in health, race, socioeconomic status, and aging. I'm very excited for our event today, which highlights common elements of family trajectories into family homelessness and housing instability, including adverse childhood experiences, or ACEs, intergenerational trauma and poverty, and institutional and structural barriers to recovery from housing instability. We will hear from one of the faculty experts at the Housing Solutions, Dr. Laura Gultekin, and a partner at COTS, LaTonia Walker. Throughout this event, feel free to submit your questions to the Zoom Q&A to be answered during our Q&A session at the end. But first, I have the pleasure of introducing Jennifer Erb-Downward, who will moderate the event. Jen is the Director of Housing Stability Programs and Policy Initiatives at Poverty Solutions at the University of Michigan, where she researches family homelessness to inform local, state, and federal policy recommendations. She joined Poverty Solutions from the Institute for Children, Poverty, and Homelessness in New York. There, she was a principal policy analyst for initiatives aimed at bringing awareness to family homelessness and for framing the city's policy agenda on this issue. She has extensive experience in policy analysis, program implementation, and best practices research around family homelessness, behavioral health, chronic illness, and the reduction of health disparities. She has been involved in the development of novel research programs in mental health and career prevention, and she's very passionate about addressing child homelessness here in Michigan, where she grew up. So welcome, Jen.
Thank you so much, Rashanik. I'm really excited to be here today. As I'm sure many of you are already aware, millions of children in the United States experience housing instability and homelessness every year. And so having this conversation today about some of the causes, and also more importantly, how do we move families out of homelessness and how do we end that experience of housing instability is really a critical conversation to be having. So I am very excited to introduce Laura Gultekin and LaTonia Walker today. Laura is a clinical assistant professor in the Department of Health and Behavioral Biological Sciences at the University of Michigan School of Nursing. She's spent the past several years partnering with community agencies to develop and implement research aimed at improving the health and well-being of families experiencing homelessness and housing instability. Through qualitative, multidisciplinary, community-engaged research, Laura is working to develop, implement, and measure community-sustainable programs that positively impact housing stability and the life circumstances, specifically exposures to trauma and violence that contribute to family homelessness. LaTonia is the director of coaching at COTS Homelessness Shelter, where she leads a team of coaches who work with families in COTS shelter, housing programs, and the community. She's a Detroit native and a leader in women's empowerment. In 2018, she founded the Ladies League of Detroit, a social network for women in Metro Detroit that is focused on professional and personal development. Laura and LaTonia will be presenting on family homelessness and housing instability and programming that COTS offers to help families to create opportunities for families to collaborate, thrive, and succeed in building strong and stable households, neighborhoods, and communities. Laura and LaTonia, thank you so much for joining us.
Thank you for that introduction. Let me get this sharing. All right, so good afternoon. I'm Laura Gultekin, and it is a pleasure to be speaking to you all today. Let's get started. So I'm thrilled to be presenting with LaTonia Walker from COTS. And as you were just hearing, she'll share a lot more about the work that she does today, but I want to take a moment and really express my gratitude for COTS, LaTonia, and her colleagues, including Delphia Simmons and Nicole Carbonari, as well as the CEO, Cheryl Johnson. These remarkable folks have had such a wonderful and shared vision for changing how families recover from housing instability and really focusing on building supports to provide stability and improve lives of families experiencing housing instability and homelessness. We do have no financial disclosures or conflicts of interest to disclose. The objectives for today are to describe the pathways into family homelessness and housing instability beyond what's available in the national data, with a specific focus on families in Detroit that are experiencing homelessness. The second objective is to spend some time exploring how collaborative efforts between community partners and academics can result in more equitable and sustainable approaches to care and intervention, and then to describe some of the innovative approaches that COTS is using to support families as they move toward more stable futures. So first things first, I need to provide some definitions. I recognize that lots of folks in the audience are experts in different areas of housing instability and homelessness, but I want to get us all on the same page with some shared language. So first, what do I mean by family? So for the purposes of this talk, and when considering the HUD definition of family, a family consists of at least one adult and 3 dependent children. Sorry. Ooh, I'm clicking on stuff I don't need to be clicking on. I apologize. While partnered adults may maintain a relationship through an episode of homelessness, they do not necessarily qualify for entry into family services or into family shelter services, and if they don't have a dependent child with them. I also want to give a bit of a lay of the land. So from the Department of Housing and Urban Development, or HUD, their annual homelessness assessment report, or AHAR, is really kind of the thing that drives a lot of the funding and our view of what's happening within the world of homelessness. So the AHAR reveals general numbers about the incidence of family homelessness, but there are a couple of really important points to note with this data. So again, I acknowledge lots of folks are familiar with these reports, so please forgive me for going into the details, but AHAR produces 2 reports, or HUD produces 2 AHA reports for every calendar year. The first is a point in time count, where every continuum of care conducts a hand count of the number of individuals and families who are physically in their shelter, as well as those who can be counted in encampments, on the street, or in other locations not intended for habitation on a single night in January of each year. So this data is typically available by the end of the same calendar year, and it ends up by default, because of this timing, being the primary influencer for funding for the following year. It's reported in the AHAR Part 1, and Part 2, in contrast, is really an estimate of the number of folks who come into service over the course of a calendar year. So a much larger picture, there is some potential for double counting of folks if they come into different service areas within a calendar year, because there's not always communication across those areas that are providing service. However, it gives us a pretty good sense of how many people are actually seeking services. So the numbers that I'm presenting on this first slide come from this second report. Here, one of the big challenges is that second report that looks at those annual estimates takes a lot longer time to produce. So this is the AHAR for 2020, which was released in late 2022. It also includes some data from the first year of the pandemic. And so one thing to really be aware of is that shelters were very heavily impacted by the pandemic. Beds had to be closed in an effort to support social distancing. Many COCs moved to different models of care where they either outsourced services to local hotels, or they just simply didn't have enough space available for people seeking services in order to provide infection control. But it makes the numbers a little bit muddy. So we see these declines, and it's great to see declines, but we're not entirely sure what this means. And when we compare this, looking at what is happening with the point in time count. And again, I recognize these numbers are small, but rather than looking at numbers, I ask that you follow the trends and the lines here. That this table reflects the point in time estimates of people in families with children who are experiencing homelessness based on their shelter status. So the blue circles represent all persons and families who were counted as homeless. The gray squares are those who sought services within a shelter. And the green triangles are folks who were unsheltered, but counted as homeless. So you can see we've had these nice reductions over time. After 2008, we really started to see some changes following the recession, the Great Recession, and things started to trend down by 2012. And we've seen kind of that steady decline over time and policy changes that were associated with it. But we see this absence of data in 2021, thanks to the pandemic. And then we start to see this uptick that we haven't seen in a long time in unsheltered families happening in 2022. And that's something that we really have to keep an eye on. And I'll talk more about that going through here. But I think a big piece of that is related to changes in bed availability, as well as concerns over COVID. So digging a little bit more into this data, in 2020, about 75% of families who were experiencing homelessness were headed by a single adult. And this is data from across the country, again, from HUD, and about 70% of those families experiencing homelessness have one or two children in the household. I think it's important to kind of keep this in mind. These tend to be small families, right? There is a real myth associated with, in particular, politicians drove a myth of families who were seeking services or engaging in having large families specifically to access resources, and it's just false. That's not the case. The other thing to note is that the typical family that is seeking shelter within emergency shelters for families is headed by a single female. So according to HUD data, 89% of these households are headed by a single female. HUD data from the AHAR Part 2 also provides some additional demographic information, and it's worth exploring this a bit because it really helps to drive the services that are available to families while they're in shelter, as well as access to permanent supportive housing. So HUD reports that about 60% of families entering family shelters are not survivors of domestic violence. And I take issue with that, and we'll talk a lot about that through the rest of this presentation. There are lots of reasons that people don't report upon entry, but that also means that those services then become unavailable to family shelters. I also want to be very clear that I am differentiating between family shelters and domestic violence shelters. Domestic violence shelters are typically standalone. Family shelters often do have some number of beds for families who are fleeing DV situations, but the services are very much differentiated. The funding for those services is very clearly differentiated by HUD, and the access to resources changes based on whether someone's acutely fleeing domestic violence or not. According to AHAR Part 2, among individuals experiencing homelessness in 2020, about 55%, so these are single adults or adults who do not have children with them, 55% have a known disability. In contrast, about 26% of adults in families experiencing homelessness have a diagnosed disability. And that's important to recognize because it impacts how quickly families can access housing in many cases. Families with disability are more likely to qualify for permanent supportive housing, while families without a diagnosed disability may have to wait longer for Section 8 housing or other similar services. So looking at the numbers in Detroit, it's a bit challenging to make heads and tails because of the pandemic. Again, this has really muddied the picture a little bit. So in 2019, the Homeless Action Network of Detroit, or HAND, reported in their annual report that there were 10,000 6 people in the Detroit COC, in that continuum of care, who experienced homelessness, with 34% of those 10,000 people being folks who were in families. In 2020, that number dropped drastically to 7,811. But the percentage of families stayed stable at about 34%. And then in 2021, the number dropped to 5,687 people. And the percentage of families from that was 26%. So it looks like this nice decline, but we also know again that the pandemic changed the number of beds that were available and altered how people were receiving services, as well as some of the immediate support and financial COVID relief that was out there. So unfortunately, the picket count in Detroit in 2022, which was counted on January 26, 2022, showed that families were now accounting for 39% of the folks that were counted as homeless on that night. So it's likely that some of the COVID financial relief, including the moratorium on eviction, increased SNAP benefits, and COVID relief payments, assisted temporarily in providing relief for families with histories or trajectories of housing instability. But we're seeing the end of that, and it's concerning that we're going to see kind of this uptick continue for a while. And in Detroit, similar to HUD data, 82% of families experiencing homelessness are led by a single female. The average family is comprised of 1 adult with 2 children, and the average age of the kids is 6 years old. So in addition to that, we also know that for every 1 household that's literally homeless, there are 5 that are precariously housed. We see this reflected in Department of Education data. Department of Education has a different definition of homeless. It doesn't look at literal homelessness as, it expands that to increase the amount of services available to children who are living in unstable housing situations. We know the number of households in Michigan that are unable to afford the basic cost of living is on the rise. And I encourage you, if you're not familiar with the Alice report from United Way, to take a peek at that. It is really useful in thinking about the numerous ways that families are struggling and the financial support that's needed to really lift families to get back to a basic supporting themselves and some financial independence. So all of that to say, we realize that that data is really, really flat, right? It just gives this one picture, one dimension. And as we were, the thing that really inspired the collaborative work between the team at UMSN and COTS was that we realized as academics, we had no sense of how families were really ending up in the shelter or how families were successfully exiting housing instability. The Great Recession of 2008 led to these media portrayals of family homelessness as a singular event that was precipitated by job loss. But as soon as we started talking to families who were receiving rehousing support services, we recognized that as a false narrative. So as a team, we partnered with agencies in Detroit who were providing housing support to families experiencing homelessness. And initially our work was with Community and Home Supports, or CHS, and the folks who were working there introduced us to HAND and to COTS. So we conducted a series of descriptive exploratory studies to really understand how families, specifically mothers, were describing their pathways into housing instability. So I'm a family nurse practitioner, and most of the members of my team, Dr. Barbara Bush and Dr. Janet Biardi, are also family nurse practitioners. And we wanted to get a grasp on preventive care. And what preventive care for housing instability look like, and really understanding those trajectories offered insight into where to focus resources for prevention. So I'm going to give a big spoiler. We haven't solved this issue. We don't have a fix. This is a problem that needs all hands. But I do believe that we have ways to make improvements. So our academic team first met with COTS while they were in the process of a real radical transformation. LaTonia is going to talk more about where they are now and kind of how that came about. But this was the first this was right after the first qualitative narrative study was completed and before we developed our narrative intervention. Then we did develop a narrative intervention. It was really the adaptation of Denise St. Arnault's existing clinical ethnographic narrative intervention, or the CENI. We wanted to modify it into a trauma-focused version, so the CENI-TF, that was specific to the client, the COTS client population, that we hoped we would be able to utilize to really help understand trajectories into housing instability, help individuals who are in that situation reflect on their experiences, think about their own strengths, recognize their own resilience, and then recognize their potential for help seeking and help them find ways to engage with others in help seeking and recovery processes. So we piloted the CENI-TF with clients of COTS. I'll talk about the narrative findings. That's what I'm really going to focus on from this study, along with the narrative findings from our prior studies, and how they really ultimately reinforced each other. In our narrative studies, 14 of the 16 participants in our first study, or it was in our second study really, but 14 of our 16 participants and 11 of our 13 participants in the CENI reported histories of either witnessing domestic violence in their childhood home, experiencing it in their intimate partner relationships prior to entering the shelter, or both. And most participants reported that they had experienced both. Very few reported these histories upon entry into the shelter for any number of reasons. So sometimes it was because the abuse was not acute, and so they were not actively fleeing their partner upon entry or their prior partner upon entry into the shelter. Sometimes it was because they didn't want additional scrutiny from CPS, or they were concerned about DV history impacting their access to housing. But there were lots of reasons to not report, and not reporting means no additional access to domestic violence services. Participants shared that they had chronic housing instability. They often started in childhood, moving house to house, staying with family members, or couch surfing as needed. Often that related to that experience of domestic violence in the childhood home. But it really ended up that folks worked so hard to stay out of the shelter that when they finally ended up in the shelter for this experience, it was their first time being truly homeless, although they'd been housing unstable for much of their lives. And that didn't get captured in the HUD data. It's again, that contributes to how people can access future housing services, their qualifications or their consideration as chronically homeless, and their ability to get access to services like permanent supportive housing. Many participants talked about having to take on employment from a young age to support their family or themselves. However, the jobs that they took on were low wage with no job security, resulting in frequent employment changes, wages that didn't lift them out of poverty, or wages that didn't balance the cost of childcare once they had children. All participants talked about fractured and fragile family and friend relationships that left them with limited social support. And oftentimes because they were working so hard to stay out of the shelter, sleeping on couches, moving in with friends or family members, they would burn those final support bridges that they had to the point that they didn't have anyone to fall back on when times got tight. So that housing instability, early parental responsibilities, and disrupted social development from all of these challenges contributed to educational disruptions, resulting in many women leaving high school prior to obtaining their diplomas. And I'd mentioned family substance use disorders, and so many women shared stories of watching a parent struggle with an SUD throughout their childhood. Women also shared their own struggles with substance use disorders, and those challenges really presented problems in finding and maintaining employment and finding and maintaining safe housing. Parental separations were also frequently reported. Participants talked about losing parents or parental figures to violence in the community, incarceration, substance use disorder, divorce, or separation. And one of the things that struck all of us, that while these women were often comfortable sharing their stories and talked explicitly about their traumas, they hesitated to consider themselves survivors or victims. Their trauma, their instability had been normalized as an expected life experience. often making it difficult to recognize a need for survivor services, and it limited their help-seeking behaviors. And I feel like those last couple of slides were really kind of doom and gloom. I really do want to note that there's incredible resilience in all of the women participants in these studies. They were hopeful. They wanted a better life. They had worked really hard to find meaning in their stories. We heard over and over that participants viewed their traumas as events that made them stronger. That all of the participants talked about education as a positive path forward, both for themselves and for their children. They had goals for themselves, but they really talked about how they were going to push their children to be successful. And participants talked about the hope and meaning they found in parenting. Children were really that motivating force when they faced struggles. They were the reasons they got up out of bed in the morning. So this is where I'm supposed to share that there is a happy ending, that the CENI-TF worked really well. And after revising it with our partners at COTS, they're now implementing the CENI-TF with all of their clients. The reality is, we realize that it's a very labor-intensive tool for use with folks who are still in a state of crisis. It required a lot of effort on the part of the coaches at COTS. And a large part of the purpose of the CENI-TF was really to encourage those help-seeking behaviors. So we created relationships with some of the mental health organizations in the area that serve the clients at COTS. And we hope to be able to do warm handoffs to encourage counseling and trauma-informed services. But we discovered really every agency that we worked with was too overwhelmed to facilitate those warm handoffs. Participants who wanted to engage in follow-up counseling discovered that there was a delay for intake that lasted weeks to months. And the only mental health services available immediately were emergency services that did not have a trauma focus. In the absence of these services, COTS' trauma-informed approach to life coaching and their passport to self-sufficiency really holds some of the immediate and lasting promise that we were trying to offer with the CENI-TF. So I think that there's still something there that's going to be really helpful. And I think that overall our projects and the qualitative data that was generated has aided COTS in garnering funding for their programming and reinforcing the need for long-term supportive programming for families who entered COTS. COTS was able to move from this anecdotal evidence, right? They were able to validate the findings that we had and say, yes, this is what we're seeing. And they were able to move this anecdotal evidence to research findings to support the need for intensive interventions for their service recipients. And this wasn't our last project. After the CENI-TF, we also did a quality improvement project with Chicago Parenting Program. There was some disruption to that thanks to COVID, but there's lots of space for additional work, and I anticipate that this relationship with COTS is going to last a long time. So on that note, I'm going to hand off to LaTonia so she can tell you about passports. I'm just going to flash up my references and say you're welcome to reach out to me to access any of these references.
Hey, good afternoon. So I'm excited to share about our work at COTS with you all. So first, just a brief history. COTS was founded in 1982. We actually celebrated our 40th year anniversary last year. Before the passport, which I'll get into, COTS was what you could call a catch-all emergency shelter. Most shelters have a specific population that they serve. And COTS served individuals, families. It wasn't specific to substance use, domestic violence, things like that, as some shelters are. In 2015 is when we became a family-only shelter. And our definition of family is at least one adult and at least one minor child. That child does not have to be a blood relation. Sometimes we do have multi-generational families where it could be a grandchild. We've even had where it's a great grandchild. It can even be a sibling, adoption, anything where the child is in the custody of that parent, that adult. Also, we do take couples to parent households. Some people think that we are only single parents for our services. And actually we do take, it can be two couples, two adults, a couple. It can also be a father. We do also have single fathers. However, the majority of the family composition is single mothers with children. So in 2015, when we became a family-only shelter, we also started our passport to self-sufficiency theory of change. And at the heart of that theory of change is coaching. So coaching, or what we call mobility coaching, is similar to life coaching. However, we call it mobility coaching because the goal is to help families who are experiencing effects of poverty, which homelessness is just one effect of impoverished situation, to help them to move forward, economic, social-wise, and things like that. And so I am a social worker. Many of the team that does the coaching may either have that background as far as education or experience. However, I do want to talk about just the difference because it's very important to our work. So coaching, one of the differences between traditional social work or case management is that it is relationship based. Whereas traditionally, there is no relationship formed. There's definitely a very clear line between the worker, if you will, and the client. With mobility coaching, we do develop a relationship. And it's also individualized. So it's not just about check boxes or resources, although we do have a variety of resources, but the focus is not just on resources. It's about that individual family that we are working with. We also use a whole family approach. We have mobility coaches that work with the parents, but we also have youth coaches that work with the children. We also have on-site daycare at our emergency shelter. And so with the mobility coaching, one of the key components, in addition to relationship building, is goals. So we work with the participants to identify what are their life goals, okay? And then support them while they accomplish those goals. We focus on 5 key areas that we call domains in the passport to self-sufficiency. The first one is family stability, which is mostly around housing, but it also involves things like vital documents, having legal identification, documents that are important for housing, such as Social Security card, birth certificates, proof of income, things like that. Next is financial empowerment, and that is where we focus on things like budgeting, saving, increasing income, even when we go further, retirement planning, investing, things like that. Next is health and well-being, where we focus on physical and mental health, and also the social network, which I'm going to talk a little bit more about later. Next is education. So ensuring that participants have at least a high school diploma or GED, and then after that to move forward in connection to their goals. So that may be college, that may be a training program, anything that's relevant to what they decide to do. And the 5th domain is employment and career. So assisting our participants in identifying employment, but then going the next step further and what they want to do for a long-term career. Okay. So as we work with our families to provide coaching, one of the things that is different with our model than other organizations also is that we provide long-term coaching. And long-term, we identify as up to 5 years. Okay, so most emergency shelters are what you would call 90-day shelters. And after that, there may be just some type of follow-up, but usually the contact is done after that. We work with families after they exit our emergency shelter, or even if they leave our housing programs, because COTS also has housing programs other than the emergency shelter. So it doesn't matter if they're in the shelter or the housing programs. It's about them being committed to the coaching. It's about our long-term effects in the community. So with that up to 5 years coaching, an evaluation that we had done found that in about 2 to 3 years is where you started to see some real life change. Okay. So that's really important because most of our families are coming from what you would call generational poverty, meaning the situation they're in is not just because of a loss of employment or a fire or a health issue, things like that. This has been a cycle and usually generational for their parents and often the grandparents before that. And so offering that long-term care and starting to see those effects within 2 to 3 years shows that the long-term programming is what's very important. Introducing an intervention that is short-term with a person that has been experiencing these things for their entire life is not going to have that long-term effect. Offering that long-term coaching is what helps to produce some long-term outcomes. So with our coaching, we also work very closely with community partners. And that's important as well because there is a lot of data that shows that organization, if you work within a silo, you're not going to have as big of effect as working together in collaboration. And so at COTS, we have many, many partners in those 5 domains that I mentioned that helps us to help our families and have that impact and introduce those services. So I have a couple of examples for you. The first one is education. So we actually have a program that we work with, St. Vincent and Sarah Fisher Center, that offers GED classes right on site. They offer them at our emergency shelter and also at one of our housing programs that's called Peterborough Arms, which is 56 2 and 3 bedroom apartments that is for families only. So that helps to eliminate the barrier of transportation because transportation and childcare are the 2 biggest barriers that we encounter with our families who are trying to seek services. So them having that option right on site is effective. Also, another partner in education is Mercy Education Center, which is more of a classroom setting. It's very good to have multiple options because every situation is different. And again, with coaching, it's very individual. So for some people, they want that traditional classroom setting. And so that would be an example of a partner that we work with where they could have that. In employment, 2 of our partners are what you would call a social enterprise. One of them is Empowerment Plan and the other is Rebel Nail. So these organizations, they have a product that they sell for a profit, but everyone that works there to produce that product is from their employment vulnerable, and they're from various shelters or social programs in the city. And both of those organizations, most of the people that they hire come from COTS. And so the good thing about those employment partners is that because they're specific to that population, they are very sensitive to the barriers that our families face. So they have more leniency than a traditional employer would have. If they have to call off because of things with childcare, when the schools are closed, they tend to either be closed or sometimes on a limited basis, they could bring the children. They also offer other supportive services, even supporting them at holiday time, helping with gas cards and things like that the first couple of months of employment as they get used to having that paycheck come in. Next, for health and well-being, a partner that we have is Central City Integrated Health, which actually is right next door to our Peterborough Arms location. They provide mental health services and physical health services. They even have a dental clinic now. And so our families are able to have that service right next door. That's also an example of a partner that we have gone a step further to higher level, where we even have a specialized number that our families can call so that they can get that expedited service. Financial domain, an example of a partnership would be Bank of America, who actually even this month is coming in for 2 sessions. So where they are working with our families to provide education or financial services, and then also assisting them in opening bank accounts, and usually at a lower rate than a traditional person going into a branch. So I want to go back to the health and well-being domain I mentioned earlier, because that is actually where we have found is the most important focus. So most of the families that we work with are coming from what you would call a draining network. They do not have a lot of positive support. And so with our health and well-being domain, we are working with our families to help them expand their social network and to create more positive relationships in their life, which often starts with us at COTS. Many of the families that we work with even refer to us as their COTS family. We also have a particular partner that's very important to mention today, and that's the Warrior Women Against Poverty. This program, they have all African-American mentors, women mentors, who are all very successful. And they are now using that to help our families that have not had those same opportunities. So creating that opportunity for them to expand their social network. That mentoring and modeling is very important. Earlier, one of the points on Laura's presentation was the normalization of trauma and ACEs. And so if you haven't seen anything different, you don't even know that something different exists. Okay. And so our coaches and that mentoring program is offering something different to show them those different opportunities. I want to end with just a quick success story. Laura mentioned earlier that some of the information may have sound like doom and gloom. However, with our coaching and passport to self-sufficiency, we have seen success. We do have success stories. One of them actually works at COTS. She had been struggling with addiction for most of her life, and now she has been sober for 7 years. And she went from having no driver's license at all in her adult life and no GED to now having a valid driver's license, which there was multiple steps to get to that I can't go into today. It is not just as simple as when you're 18 and just go and get your driver's license when you haven't had it for years. She also now has her GED, which she worked in partnership with the Warrior Women Against Poverty and her COTS coach. So she, after attaining her GED, now is in college at Wayne County Community College and is almost done with her associate degree. We also have a family that resides at our Peterborough Arms location, who went from some of those same circumstances to now having her associate's degree and working at another community organization, making a livable wage. And then finally, a third example, we have another individual who works at one of our employment programs that I mentioned at Rebel Nail, who went from no identification, no employment, no transportation, children not in school, to now having legal identification, long-term employment at Rebel Nail, and building her own business, which she now does work at COTS with her photography, being the photographer at many of our events, and also did the headshots for our full leadership staff. And so I wanted to end on that note, because the creating opportunities to succeed is about having hope and knowing that there is opportunities for our families, despite the trauma and negative situations that they've come from, that there is positive support and there are successful outcomes. So I end today with letting you know that at COTS, we're providing hope and opportunities to succeed for families in Detroit. Thank you.
Thank you so much, LaTonia and Laura. That was a really great presentation. And I love how you're ending on this message of hope. We have a number of different questions that have come in. So I'm thinking, why don't we start on this point of hope? I would love to hear, based on the work that both of you have done, maybe from each of you, what would be your vision for what you would like to see happening? Like, these programs you've talked about seem to have so much potential. How would you like to see them expanded, or what are opportunities that you see that really we could all be moving forward with?
Okay. I'll go first. One of them is more employment opportunities, particularly, like I mentioned, the two social enterprises that we work with. But even if it's traditional corporate America, them becoming more educated on working with a sensitive population, offering more opportunities for them, and things that will make it easier for them to keep that employment. Okay, so sometimes there's this narratives about why people coming from these situations cannot keep employment, and usually they're false, is that they need that support. They don't have usually the traditional family and social support. So maybe having more childcare on site, offering some type of support with transportation, things like that.
Great, Laura.
Yeah, I
Oh.
have similar answer. I think it's kind of really expanding those opportunities for families for recovery, whether it is more trauma focused and trauma in specific interventions to help families move beyond that experience. We know that those are labor intensive processes in recovering from the trauma that most of these families have experienced is really labor intensive, but those social support pieces are so important, as is creating opportunities for stability, making that kind of the default, whether it's employment stability or social networks that are stable. Just building on those pieces that COTS is starting to put in place, and expanding that is so important.
Thank you. That's it's great to think about more. So another question that has come in is just about the landscape of housing instability and homelessness in Detroit. Can either of you speak to thoughts you have on how that landscape might differ in Detroit versus other places in the United States?
So I think Detroit is a little bit unique in that it's, that it's had that shrinking city status for a long time. One of the stories that I have to say, I was honestly gobsmacked, but we heard it so many times from so many different women that we spoke with, but the experience of being, believing that they were renting a property legally, and then discovering that the person who was renting them the property was not the actual landowner or landlord. And so the rug was pulled out from them all of a sudden, whether it was they came home and literally found their home demolished, or they were evicted with no recourse, no financial recourse. I think that that's something that just the number of homes that had been abandoned and ignored by the city for a long period of time contributed to this problem. And really, I think that's a very different situation than you see in a lot of other parts of the country.
I think also there's a lot of slumlords. And sometimes when our families do move in homes, even if it is, legally that person or company's home, there's often a lot of repairs and things that need to be done, which is hard to get done. They go through the proper channels, but because a lot of them, and I don't want to paint the picture that all landlords, but the ones that are slumlords, they know that they're working with a vulnerable person or family who doesn't have those resources. And so, just doing some quick patchwork or sometimes not responding at all. And so that makes it difficult because now going back to even employment, you have a person who may be trying to work, but they're have to call off and they're dealing with things like leaks and bad plumbing and things at home where they don't have that stable home environment to be able to focus on those other things such as employment and school and education. And then the danger of that as well, having children in a home that, has these things going on. So I think more standards and involvement to make sure that the housing is quality and up to standard for vulnerable families to live in.
Great, thank you. That's I think those are excellent points to think about in terms of Detroit. I have another question that's coming in that is just it's trying to tackle this distinction you made, LaTonia, between social work and coaching, and it's sort of wondering where the therapy piece fits in there in terms of, is there sort of a difference in how therapy would operate in the context of this more coaching model versus, more of a social work model. And I would love to hear both of your thoughts on this.
Okay, I can go first, Laura. So yes, coaching is not therapy. And we do work in partnership with community programs such as the one I mentioned. But we also have a variety of mental health organizations that we work with, both for parents and children. So as far as just the difference still with coaching versus the social work and the individual approach, I think for one, the long term is a key difference. And then also that it's not just about certain resources or whatever is even on trend. This is being offered, so you should do that. It's know what you like to do. We do talk about those things with their traumatic experiences, including when Laura shared about the Cindy tool. We also use the ACEs questionnaire. So we do talk about those things, but if they need more care or want to seek services, that's where we connect them with a partner. But we talk about those things because that's important to building the relationship and also knowing the history of what that person has gone through to now help them with their future.
And yeah, I think that LaTonia's view of that and experience of that is so important, and her direct care is so much more informed than I can give in terms of the difference between therapy and life coaching. But I will say that the role of therapy, I find in terms of working toward recovery and resolving some of the reactivity that happens after trauma is really important. I think that it happens naturally within that coaching setting, but sometimes that awareness that comes with the therapy piece is, and partnering with other outside services to do that, to get to that space is really important in terms of long-term success and recovery.
Great. So another question, and this is in a little bit of a different direction, but we have a question from the audience around the intersection that you both see in terms of thinking about some of these coaching programs. You mentioned that, how important children were to parents and how much of a motivation that was and how much they wanted to see them their children really succeed in school. So the question really is about what is the intersection in terms of those coaching programs, the public school system in Detroit. Do either of you see opportunities in terms of building more connections there, or how these systems could be operating more effectively to support families? That's generally the broad scope.
So as a clinical professor, my current clinical placement is actually over at the Early Education Center at Marygrove, which is run by Starfish. And so they provide some big supportive services for families, in particular kiddos who are experiencing some behavioral disruptions and some behavioral challenges, developmental delays. And one of the challenges I think that is found across the board is getting children connected with services early. So those early intervention services that are supposed to exist, that simply there's not enough of those services available for the amount of need. And so I think that there is a huge need to find additional routes or approaches to helping support those families who have little ones who are struggling, especially in the context of, again, I'm sorry, I'm going to talk about trauma. In that context of trauma, we know how very directly it impacts development, it impacts behavior, it impacts someone's ability to learn. And when we're not able to disrupt the challenges or offer early intervention services, we see children who really struggle in maintaining educational attainment.
And so the coaches do work with parents to help them work through some of those challenges in the school system. I can't speak to what's exactly going on in the school system or them developing coaching, because that's just a bigger conversation. But I can say our supports to work with it. So for example, we have a position as a community liaison, and a big part of that role is helping parents to work through like getting an IEP and things like that. Or if the child is enrolled in virtual, because even though we're at a certain point in this pandemic, there still is like a split. Some children are going in person and some are having virtual school. So ensuring that they have like the proper tools. We have a learning lab on site that through a funder we were able to establish during COVID, where it's like a classroom setting, and we have 2 staff that are present to help the children to be able to properly enroll. Log on, on the computers. We do have the computers and everything on site, because that was something that we found once we were in the pandemic, that many of the children who may have already been struggling in school were now definitely struggling with virtual school. And so providing still that classroom setting and the equipment that they need. And then that liaison, and sometimes also the coach that can work with them to try to get an IEP if needed, or also to enroll them in other services such as the Children's Center, which is another community partner that we work with that offers services to children.
Thank you both so much. This has been a really wonderful conversation. I'm going to pass it back to you, Rashanik, to close us out.
So I could be here all day. I would like to thank our speakers today for this wonderful session, and thank the viewers for joining us today. We will host our final event of the winter 2023 Housing Solutions Speaker Series virtually on April 13th from 12 to 1 p.m., where we'll bring together Rob Goodspeed, who's a professor over at Taubman College of Architecture and Urban Planning, April Faith Slacker, who is the director of the City of Detroit's Office of Eviction Defense, and Libby Benton from the Center for Community Progress to discuss eviction and displacement in Detroit and around the state. Thank you again to Laura, LaTonia, and Jen, and I hope to see you all very soon. Take care. Bye-bye.